question that we had for programmatic was, will there be a maximum number of visits a child can receive? The answer to that question is no. And the second question, or will there still be certain maximum amount annually for which a program can be reimbursed, similar to our contracted amount now? If not, how the state can budget that very unknown variable. Of course, the contract numbers are no longer going to be in effect with this new rate system. You will not have a certain amount of children that you can serve. And as always, we expect services to be provided based on the needs of the family. So if you were providing 2 services a month for a child, and then when this new rate study goes into effect, we would expect that you would be delivering services or rendering services based on the child's concerns, outcomes, and needs that were set forth by the team, the family and the team. So, but there will be no cutoff as far as how many children that you can serve. The next question is, will there be training on teaming so programs can know how to make the right decisions on service provision? The answer to that is that training on teaming is already provided in Journey 1 and Journey 2. So you can get that training through that, but you can also request through your technical assistance, through your monitors. If there's something that you need to hit on more heavily as far as that goes, then you can always ask your monitors for some technical assistance on that. The next question was, what flexibility will programs have when they are full and cannot take additional referrals? Will the referrals only come from the geographical areas agreed upon in advance? What role will DEICs play in the transition? And then after the proposed rate structure is in place, if programs are expected to serve all children? What guidance can you share for programs in meeting IFSP requirements if they receive additional referrals over their capacity? Programs will have the flexibility to decline referrals if they do not have the capacity. Capacity will be set forth by your program as an individual. So if you feel that your program is, you set whatever you feel like your capacity is, that will be what you decide as a program, but we will not decide that for you. However, referrals cannot be declined based on the type, the services needed, or geographical regions, meaning the type is you will not be able to, we would ask that you not specifically ask for referrals based on their race. Like we want children that are not Hispanic because we don't have interpreters. We would ask that you don't ask for certain services rendered as far as we will only take children who need speech or PT or OT or special instruction, or the geographical region. So on your contract or on your agreement, however we decide to send those out to programs, you will make that decision on what counties that you are willing to serve. And if you're serving Montgomery County, we would expect that you would serve all of Montgomery County. So those are what we're saying about referrals cannot be declined based on those 3 areas. As an EI program, you will still determine your geographical service area. As always in the contracts in the past, you will decide what areas that you decide to serve. And the DEICs will continue to play the same role that they play now. The next question was, in what ways do you expect the current EI service delivery model to change? Again, as always, we expect services to be provided based on the needs of the family and that what are on the IFSP. Next question, in what ways will the proposed rate structure help decrease job turnover and recruit quality professionals to the field? There isn't a way for us to answer this question at this time. Is there ever a situation or scenario in which children can be seen in small groups for work on skills related to social emotional, communication, preschool readiness, transition? What about situations and scenarios for providing center-based opportunities for skill development? The answer to those questions is no. The next question, will ADRS get input from programs on gifts revisions to make sure it will work for everyone? Yes, Tanya has been asking for wish lists since the decision to redesign gifts. So she is still taking those items from programs. So feel free to turn those in as you anytime that you think of something that you're wishing for in gifts.
Hey, Amy, I think y'all froze unless it was on my computer. Can you go back and do question 10 and maybe 11, or am I the only one that froze up?
I think it's you, Jerry, because I've heard her the whole time.
Gotcha. Good. Thank you.
Okay, the next question is, how will programs overcome non-compensation for parent cancellations and no-shows on a strictly fee-for-service model? Is there a way to compensate providers who drive out to the home and the family is a no-show even after reminder confirmations? Can programs receive some level of payment for no-shows and cancellations for any appointment that occurs with less than 24 hours notice? Programs would be reimbursed for all these activities through the billable factor that Shay went over earlier that was calculated in the rate. Next question, if an EI professional is at home for a full hour visit, will the provider be able to charge a total of 1 hour when the parent is late, child gets sick or falls asleep, parent steps out of the room, and the visit is less than 1 hour? Is it correct to say that under the new system, Medicaid codes will be time-based, not treatment-based, as therapists are currently used to? The answer to that first question is no. The billable units will all be in 15-minute increments, except for evaluations. All other services are based on time and personnel classifications, and we will follow the same rules as Medicaid when it comes to the 15-minute increment billing. The next question is, if you were in an EI provider, which an expected caseload of 100 EI families, please share your thoughts regarding a sample budget based on a 15% admin rate, staffing structure, salary range per professional, caseload and service frequencies based on an average IFSP, and anticipated unbillable time due to travel, paperwork, cancellations, trainings, holidays, and personal leave. Without a contract in place, does PCG have any advice on how the proposed rate model will vary in revenue and expenses from previous years through their work experience in other states? The rate structure, again, was built with all of these factors built in. This rate structure will impact each program differently. That is the end of the programmatic questions, but if you have any other questions right now, feel free to ask those questions or put them in the chat.
Hey, Amy, it's Jessica Letson. Can you repeat the question and answer regarding no-show visits, please?
Let's see, where was that? Number 14, I believe. How will programs overcome compensation for parent cancellations and no-shows on a strictly fee-for-service model? Is there a way to compensate providers who drive out to the home and the family is a no-show even after reminder confirmations? Can programs receive some level of payment for no-shows and cancellations for any appointment that occurs with less than 24 hours notice? Is that the question?
Yes, that is.
Okay. Programs would be reimbursed for all these activities through the billable factor that was calculated in the rate.
Okay, I'm sorry. Maybe it's just me, but I'm not quite understanding that answer. Can you elaborate a little bit on what's billable related to a no-show visit?
So, Amy, you want me to jump in?
Yeah, sure.
Okay. As we were going through that rate and we were talking about the billable factor, remember we took direct time, personnel time, salary and fringes. We added in the administrative cost to support that person providing those direct services, the 31.20%, I believe. And then we added the billable factor, and the billable factor is to account for all of the technically non-billable time, like no-shows, that were being provided. And that was added in as well. So again, you're coming up with your hourly rate. to actually provide the direct services. And then we're increasing that amount by the billable factor to account for all of those indirect activities that your direct service provider is incurring, like no-shows. So instead of paying, I think it was 56 an hour, we would be paying 120 as an example. And that way you would be compensated for those no-shows, even though you're not directly billing for them.
And I'll just jump in and add, during the time study, there were no-shows. During the time study, there were administration times, there were staff meetings, there were holidays taken, there were personal leave days taken, sick leave taken. All of that is taken into account to then inflate that rate with that billable factor to cover those expenses to you as a program.
Okay, Shay, and I have a little bit of a question on not being able to see a program that would work. Okay, I'm a numbers girl, so I understand how this on paper looks great, but if you as an agency haven't flipped it and made it actually work with what somebody's doing, is it accurate?
I was just going to say that it is accurate because it's based off the information that all the programs provided. And we had a really good participation rate, more than most states, according to PCG. So this was based off of the information that was provided to PCG by the program. So I don't know how it gets much more accurate than that.
And I just would add, PCG would share with us, for instance, if a rate came in and it looked unusually high or anything looked low, they would say, okay, here's what we looked at in other states. And then you ask, okay, how do we know it will work? So in EI programs across the country who receive federal grant only or reduced state funding from what we receive here in Alabama, those programs are serving their children with the rate and are making it as programs. In fact, the increased administrative time that is factored into your rate and the cost that we're covering is actually at a higher rate than those other states. So hopefully I hope that answered your question.
That helps.
Also, I think Stephanie Logan from Medicaid has a question.
Yes, my question also was surrounding the cancellations. Does this factor in Medicaid kids, or this particular no-show rate will be paid from a different pot of money?
So there isn't a no-show rate, billable rate. What was included in the rate, the total rate, is three different things. That rate was calculated based off costs provided by the programs for their direct service provider time to actually provide the service, the administrative time that is incurred by the direct service providers, like I went out to a house, but the family wasn't there, the baby was napping, etc., or they just didn't show up, etc. That is the indirect time that isn't billed, that those were the costs that they were incurring. And it also takes into account any administrative costs for administrative staff and personnel, the overhead, if you will, of the program. So those three things were included in the rate buildup to come up with a rate of service for the service. It isn't billed outside of that.
And Stephanie, I think further answer the question, one of the recommendations from PCG is that we pay the same rate through Part C funds as we do for Medicaid, so that those match, so there wouldn't be a difference between what the EI Part C dollars are funding and what Medicaid is reimbursing.
Okay, I'm trying to see the picture, guys. But for example, you go out and you see Charlie Sue. Charlie is a Medicaid child. Charlie parents was not there. Are you gonna go back and bill Medicaid for Charlie? With all this, you're not gonna put a claim in the system for Charlie because Charlie was not there.
No.
Exactly.
Okay, so as
Correct.
long as the answer is no to that, I'm fine.
Yes, no, we're not.
Just to kind of expound on that, so everybody kind of understands. So they do go out and provide an hour of service for Charlie, and they are billing, as an example. Again, we're still coming up with the final numbers, but $120, right? That is to take care of that direct service provider's hour that they spent with Charlie, and then the additional 1.23 hours of non-billable activities like no shows and things like that, actually traveling out to see
Case
Charlie,
notes,
case notes, all of that.
team meeting, whatever it might be.
Right, exactly. So that above the 1 hour, that's to cover all of those additional activities that are being provided to provide for that hour of service, just that doesn't rise to a billable claim. So short answer is no, we would not file a claim to Medicaid if there was a no-show. But we have accounted for those in the program cost as part of the rate buildup.
Understand, thank you.
I had just a follow-up question on the vacation, because I know some put that in their rate study, but my guess is a lot of us did not purposefully pick the 2-week period that we had staff out, because we wanted you to see the activities that we really did. So a lot of the leave would not be included in that rate study just from that snapshot. How are we addressing the Decembers, the summers, the spring breaks, and the things where there's whole gaps of staff being gone, which would not have been included in the rate time period?
But you did turn in, Cheryl, what you pay your staff and what your fringes are. So all those fringes were accounted for in that overall staffing cost. So just like with your contractors, you don't have those additional costs. With your full-time FTEs, you've got information that you provided about what is your total cost for those employees. So PCG took that into account in the rate study.
Yeah, just that comment that, it came out in the rate study, I knew it wasn't from us. I was just wondering if you factored that some other way. Thank you.
Questions for programmatic?
I think we have a question in the chat. Let me see. I think Jessica has a question. Let me see if I can get to it.
Jessica Lesson said, in the last ICC meeting, you mentioned co-treatment being a billable service. Does this mean that it satisfies the requirements of the IFSP plan service?
I'm not exactly sure if I understand that question, but if you're asking about co-visits, that was built into the rate, so that is a rate that would be it would be billed as discipline specific. Whoever goes in to do that co-visit would bill the same rate that you do as being in there as their discipline specific. Does that answer your question?
Yeah, I think currently if let's say a speech and an OT go out together, if speech is on the plan once a month and OT is on the plan once a month and they go together, only one of those services can count towards the plan services for the IFSP. And we're out of compliance if we provide the additional service separately. So I'm just wanting to make sure that if they co-treat, that still satisfies the requirements of the IFSP.
We're also going to be releasing or talking about policy.
Felicia, you're breaking up really bad.
Is it better?
Not really, but keep going and see if we hear you better.
Can you hear me now?
Yeah, it's you're still breaking up, Felicia. Sorry.
I'll go to another office.
It's fine. You can get back with me on the answer. I don't have to know it right now. I just want to make sure that we do understand that correctly for the future.
I just want to point out to Jessica that is an area that we'll need to develop policy around. That's one of those unknowns that we've got to work together to figure out what kind of policies we put in place for co-visits. What are some parameters particularly we put in place? Since both of the therapists would be able to bill, you know, what's the max amount, you know, that kind of thing. Do we need to place caps? Those are questions that we've still got to answer.
Okay, thank you.
I think Michelle also had a question. She said proposed Medicaid rates show service coordination rates going down. What led to this rate?
First of all, you were able to bill for service coordination through Medicaid now, but you weren't able to bill Part C dollars for that in the past, and you will be able to bill for that as we move forward.
And again, I go back to these were based off of the costs that were presented to PCG. So that is how that number went down based off of what was reported. But I believe the commissioner touched on it a little bit earlier when we were talking about the 45% billable factor. Service coordination's billable factor was actually much lower than that. So the commissioner, as we were discussing this with PCG, asked for the 40% in order to make sure, because she understands that service coordination has a very heavy administrative piece to that function, and wanted to make sure that that was accounted for. So it's actually a little inflated to what was reported on the cost studies. And again, that was to account for the heavy administrative burden that the service coordinators see daily.
There's another question. Can you tell us the average that was used in mile and travel time? What was the average miles built into this rate? Example, is it 10 miles, 70 miles? What mileage and time was used?
I think that's a question we're going to need to look up the answer to and let you know.
Okay, we'll get back with you on that. I think I got all the chat questions.
And Felicia was, she put something in there that says we are trying to get two separate rates to differentiate service coordination and special instruction. So,
okay.
I'm sorry, just real quick, I'm going to read this. So I say it exactly how PCG presented to us. Travel expenses were removed, but they were based off the cost instrument that captured specific travel related costs, including staff mileage reimbursement and parent mileage, child family transportation, and other travel. The percentage of costs reported as mileage were calculated from the total expenses, equaling 3.31% of all Alabama Early Intervention System expenses. So that's how they came up with the 3.31%.
Okay, thanks. There's one more question. Can you explain why the rate for developmental specialists is so much lower than that for the discipline-specific providers? Most of our developmental specialists have similar amounts of experience and years of education and are licensed in other areas, but still serve as DS. I think we answered that in another section.
That's in another section.
Yeah. So we'll get back to that one, to that question in another topic. Okay.
Deborah, this is Jane. Did you answer Kay's question about right now two providers can go out, but they can't do it on the same day?
Well, that's where we said we're going to have to develop policy for those co-visits. Yeah. Now, as far as two providers going out on the same day to see the family, but not together. Some of those are Medicaid requirements, and it's not an early intervention requirement.
I just remember at the ICC meeting, it was brought out that PCG brought out that because the model for early intervention is to do that is a evidence-based practice to do some co-treating, that this would hopefully help with that when policies are developed. Am I right? Or did I mishear that?
Yes. And
She's talking about it's not a co-visit. It's just you happen to schedule them on the same day.
Gotcha. Okay.
I have a question, and Shay, you may have answered it, but when PGP was looking at the mileage, did they also look at the area where if you have company cars and you weren't paying mileage, but you were putting gas in cars and expense for the wear and tear on those vehicles? Was that considered when they were considering the mileage rate when you guys got the 3.some%?
Yes.
Yes, because again, it was what was reported. Each program has their own specific policies in regards to how they're reimbursing for mileage and travel. Some have cars that folks are using, some are using their own personal vehicles, but it would have shown up through the costs that were reported by each program when they reported the cost for mileage.
I have one more question. And so did we take in consideration serving rural counties and travel as it relates to those rural counties? And if so, how was it and where was it taken in consideration at? And do we think this new model will address being able to provide more services and more people wanting and therapists to go to these rural counties that are underserved?
That was a big question. So if I start to meander, tell me I'm not answering the question. To the first part, again, yes. If programs, when they were reporting on the time study, as well as in their cost report, we're getting a full year of costs in the cost report. So we would have picked up costs associated with traveling to the rural areas because there would be more travel costs. The time study, if programs were traveling and they were recording that time, that would be included in the time as well. So to answer your question, traveling to both, rural versus non-rural would have been picked up. It was part of the discussions with PCG. We saw a lot of travel in just the metropolitan areas and surrounding areas. That's where, a big bulk of travel is because somebody around Birmingham, Homewood could be traveling as much as somebody who's traveling, to the more rural areas just in a day because they're jumping from one place to the next around that metropolitan area and seeing a lot of kiddos. So yes, that was. So repeat the second part of your question. I want to make sure I'm answering it.
Yeah, I was just wondering, how does this new way of getting reimbursed in fee-for-services will help us recruit more therapists that's willing to serve in these rural, underserved, especially our Black Belt counties?
Well, there's two parts of the question. I feel like I can confidently answer one. The other part of the question, I think, is more of a programmatic question and would love to hear from the program on that. But the important thing to know is we're trying to address the cost disparity as far as transportation costs in order to be able, and the time, not just the transportation costs, but the actual time of providers having to travel to these rural areas to provide services. So we want to make sure that if you're foregoing serving 4 children locally to go see 1 child in a rural area, that we're accounting for that. So mathematically, in the rate calculation buildup, you will see that we're trying to do that, and that PCG captured that. Now, as far as the rest of it, I think that's more of a programmatic question. So Amy or Felicia, if y'all could jump in on that one.
Well, I can say about recruitment and retention. I mean, we know that nationwide that's an issue. We have shortage of providers, but I think what we're planning to do is to recruit new programs to come into the system. So whether that's through an RFP or other ways to recruit more providers who can serve in those areas, that will be something that we will be looking at as far as recruiting new programs to come into the system, if that makes sense. I don't know if anyone else has anything to add to that. Did that answer your question?
Yeah, we're all trying to recruit therapists, and so I just don't know if new programs are going to have more tools because, therapists are therapists. But anyway, yes, ma'am. Thank you.
Okay, well, we're gonna move on to the DMH questions. I got the short section. Why was DMH's 1.6 million MOE not factored into the rates to help providers make anticipated cuts less severe? And the rates were calculated using program costs, not available revenue. And as a proposed rate system is phased in, is there a plan to help ease the financial losses of programs as they transition to the new rate structure? Can MOE funds from DMH and or AID be used for this purpose? And is there another plan for the MOE funds? And the rate study took in all relevant submitted data into account to ensure that the cost to serve the families would be covered. Any questions for DMH?
So Deborah, a lot of those, the MOE funds, which is the reason why you guys and Jane gave those to us, was for the purpose of travel, training, those kinds of things. The rates are going to serve families. Where is the extra makeup going to be for those trainings and things that we use the MOE for?
Go ahead, Shay. I see you.
I'm sorry, y'all are gonna be so tired of hearing my voice, my crackly voice. So the training, again, the time for training, the administrative piece, the indirect activity piece, has been accounted for in the rate buildup. And so it covers all those items. As the other part of your question, I want to make sure I'm answering it.
It was about the MOE dollars that we use for, like, if we had our Journey 2 training and send our staff or have our staff sit through Journey 2. Those are some of the things we use for our MOE dollars, and those are specific, what we always heard for years. Jane would say, you've got this money, use it for training, get your people in training.
So the nitty gritty quick answer is now you would be getting reimbursed through the rate, the billable rate when you bill as part of that billable factor, instead of that additional MOE fund.
There's some additional recommendations, Michelle. I think you may have seen in the recommendation in the PowerPoint that talks about training and for us to develop some asynchronous training such that you would have less staff time away. Those are the kinds of things that we'll continue to look at as well. That training component, how do we reduce time out of service provision in that administrative time piece? The rate is built around to try and cover those costs for you. But we as a program want to continue to try and figure out how we can reduce administrative burden and allow you to provide as much direct service as possible, which would lead to obviously billable time. So those are all things that we look at. I guess the biggest question probably behind those questions, if I had to guess, is where's the DMH money going? I don't have an answer for that at this time. I can tell you that PCG's recommendations were taken into account. We had conversations internally. We then have met with Commissioner Boswell and her staff about some of our thoughts around where that DMH money might be able to support the system as a whole, not just a handful of programs, but the entire system. How might we be able to support the system with those funds? I obviously don't control DMH dollars. That's not in my command. That's under Commissioner Boswell, but I have shared my thoughts with Commissioner Boswell, and we'll maybe have more for you in the not too distant future about those funds.
I was thinking too, like the EI conference is coming up at the end of October. It's in the new fiscal year where some of these changes might be taking place. And if we don't have those MOE funds or different things to send staff down to Mobile, which is an expensive conference, how is that going to be factored in with trying to watch program budgets within the first month of this being rolled out?
I agree. This is Abby. I agree with Michelle, because it kind of hits you on both ends for service coordinators. If you're attending training, you're not doing anything billable during that time also. So, it's taking time that you're paying a service coordinator for, and they're not doing any direct fee for service activities then. And I understand what you're saying. You're trying to capture all that in the rate, but we have a significant amount of training.
Right. And I think Amy spoke to this before. Service coordination was being billed through Medicaid, but you couldn't bill Part C. It was not set up for that. Whereas if we are going in this direction and these are the numbers that we land on, you will be billing directly for your service coordination time. And part of that is, again, that 40% billable factor. So for every hour of direct service you're providing, you're getting money in addition to that for those times that you can't bill for training. So,
yeah, I understand.
Okay.
Because the person coordinating the EI conference, this is concerning to us because, we're trying to.
Cheryl, I can't hear you at all.
The volume, it's the volume.
Okay, let me check. Is that better?
It's a little better.
Yeah.
Okay, I have it. Okay, I'll talk louder. How's that? Is that better?
Yeah, that's good.
Better.
Okay. As one of the individuals working on the early intervention conference, it is very concerning since we have a lot financially at risk of, all these hotel rooms under contract and, all these speakers we're bringing in. So with all the uncertainty, it would be great if we could offset the training time by a mechanism of maintenance of effort, because otherwise you're creating a system of disincentive, for people to leave and do training and not have those billables. So, if we could look at the MOU for us being able to bill out the time that we're at these either required journeys, the early intervention conference and things like that, that would be very helpful to not create a system that de-incentivizes, the keeping sharp on your skills.
So I just want to make sure I understand the issue, because I'm the accountant in the room. Is the concern with the conference being held this year or in subsequent years after whatever changes occur are in place?
I don't think we know. I mean, because, we don't know. I mean, it's an unknown. So like with this year coming in, do we send, like for our program and larger programs, 13, 14 staff to a conference spending money? We're not for sure that we're going to be able to recoup that. And like Abby said, if service coordinators, I have 7 service coordinators, that's 4 days of non-billable time that won't be billed out, and that's lost money, but yet money spent.
Yeah.
So a couple things. First of all, nobody panic. This isn't going to happen overnight. There's a lot of moving parts that got to be put in place. So I can't even say October 1st without hyperventilating. So just know that's still a moving part. So I don't want anybody to kind of go into a panic as to current year being able to bill and et cetera and funds, because that's not the case. So I want to make sure everybody's aware of that. The second piece is, again, and I know I sound like a broken record, but the rate buildup is such that we have accounted for time where folks are being sent. So although you're not able to bill directly for that, you are being compensated for it through the rate when you do bill for direct services. So all that time should be accounted for, and you should receive funds when you're billing those direct services.
But the practicality is, like Michelle's saying, and the other is saying, if I can send 3 people down and bring some information back to the rest of the team, the others are getting paid. So how many am I going to send? Am I going to send all of my, like for Michelle, her 7 service coordinators who need this information, or is she going to send like 2 so she can get billable? So it's disincentivizing all of our early intervention providers to attend and be up to date on training.
So what I can tell you is the rate includes the cost to send your folks to these conferences. Now, as a program, if you make decisions,
Jay, can I jump in?
Mm-hmm.
It sounds as if obviously Journey 1, Journey 2, those are things that we're looking at to increase asynchronous capabilities, some other items to try and assist you as programs. It sounds like the EI conference is the big point of contention and question marks around that. So what I'd like to do at this time is kind of say, let us step back, have a conversation about that, and then get back with you at our next meeting. Because it sounds like there's a lot of discussion there.
Well, and can I just say, because it started out talking about the DMH MOE, only 23 programs get DMH MOE currently. So all of the other programs are sending people to EI conferences without MOE. And our MOE is not just for training. I just want to make sure that's clear. That is not, it is one thing that can be used. They can be used because Part C has never been given specifically for service coordination, billable hours or whatever. That was originally back when Alice Widgeon was the EI coordinator. She came up, I believe it was her decision to compensate DMH programs. At that time, we were doing targeted case management as well, to compensate EI programs for non-Medicaid children for service coordination. That was the original intent of MOE. When we stopped doing TCM, we kind of shifted some of our we said, yes, use it for non-billable service coordination, but also we were encouraging our providers to get their folks trained. So I think that's where they're coming from. But again, that's not, I mean, other programs have figured out how to send their staff for training. I'm assuming, I don't think only DMH staff go to EI conferences. So I'm just saying that, that I think that's part of where Michelle and Cheryl are coming from. I could be wrong, but.
This is Glenn Harger. Can I ask a question?
Sure.
Commissioner, if you're going to take a look at this training and how it affects EI, got to remember the EI conference is the training session for early intervention in this state. Just be sure you got somebody from our committee that's part of providing information to you. And I'm not going to whine about what it's going to do to the conference, but it'll have a dramatic effect if there's no travel money allotted. And I realize that I'm beating a dead horse here, but you think that average rate covers, just using mileage as a thing, if you operate in rural Alabama, then you're going to drive way further than you are from East Birmingham to West Birmingham. And we've been facing years, and it's the thing that kills us in these programs. You got to remember that the early intervention program is the single hardest program that a vendor operates, and I can speak to that dramatically for the last 30-some years. So it's those kinds of things that I think that are. And you're going to have some, I keep hearing you talking about starting new early intervention programs. I'm trying to figure out, how does that help the process? That really is, I don't understand that. You got programs that are already operating out there. And apparently the way the average worked, it took the high and the low and landed somewhere in the middle. So the ones that were on the high end are the ones that are going to suffer the most. And we're going to put some people out of business. So you just need to know that.
So Glenn, you had a lot there. Let me try and tackle each little section. One, the EI conference. To Jane's point, DMH is the only set of programs, those programs that receive additional funding. So really, when I'm talking about going back and tackling any questions about EI training, it's about how the system can support training for staff. And that conference specifically. So those are, and we of course would include people who know what it takes to put that conference on when we have those discussions. To your point about adding additional programs, we served 768 additional children. DEIC caseloads are busting at the seams. Your contract numbers, we continually try and push to get you to serve more kids. There are kids that need to be seen. That's why we need additional programs. The numbers aren't going down. They're going up. 768 was kind of a benchmark year, a watermark year, I should say. On average, though, we have served an additional 300 to 400 kids per year for the last decade, every year, year over year. So we do need more programs. And I'm trying to remember the middle part. The middle part is actually what I wanted to respond to first. And I got sidetracked. Rural areas and travel time. In the rate, earlier in my opening comments, I talked about some things that we left in. One that I didn't leave in that conversation was that our windshield time, what I call windshield time behind the wheel of the car driving to rural areas in Alabama. When we talk to PCG, our windshield time is actually higher than any state they've seen. So all of that was taken into account. So if you traveled a long distance to see a kid, that got built into the rate. And we actually built in more travel time than any state that PCG has worked with in the past. So I just wanted to point that out. So that is, in fact, built in to the rate.
Commissioner, one thing, this is Benita Batiste. I'm with UCP of Mobile and in the conference room with Glenn Harder. I think one thing that conversation about travel doesn't consider is that the productivity rate is very, very different in a metropolitan area than it is in a rural area. So I may have the same windshield time in Montgomery or in Birmingham, but I'm getting paid 10 units. If I'm in Clark County, I'm seeing I have the same windshield time and I'm getting paid for 2 units. There's an extreme difference. And I understand what Shay was saying, that this is all about cost. But the problem is we are going to find that service, what this is doing is incentivizing people to create a lower level of service for the most part. As you asked us to define our counties, if we decide that it's too costly for us to serve rural counties, then we'll restrict our areas to just metropolitan areas because we can increase our productivity. So those new programs would need to come into those rural areas. And how are they going to come up financially with a structure that allows them to be solvent to do that?
So I happen to disagree with you on that this disincentivizes service provision. To your point, I do hear you when you talk about rural areas. Rural areas are hard to have service provision now. I think that will continue to be an issue and one that we as a system have to look at and try and address. But we're trying to address that now under the existing structure. I don't think that will change under the new structure. Fee-for-service models actually incentivize service provision. It's been shown across the country. That's why most states have a fee-for-service structure model. And in Alabama, we currently, I want to remind you, serve children directly about half of the time of the national average. So we've got to try and figure out how to incentivize the provision of services to those kids, particularly complex kids, and reimburse you for your costs to do so. So if you serve a kid 3 to 4 hours a month now versus, let's say, 2 hours a month in the past, one, you're going to cover cost and you're going to bring in those funds. And two, that child's going to receive all the services that they need. So I think it's kind of a win-win.
Commissioner, this is Christine Smith from UCP. So one of my concerns is with getting staff, getting therapists. So maybe the child's being seen more often than before. But I feel like then that's going to make it to where the programs can serve less children because we don't have the staff to see. Does that make sense? And then so a concern that I have as well is if we're going to start new programs, where are these people going to come from? I know that we have a hard time finding people and providers, especially in certain areas. Where are these people? How are we going to recruit these people to come work for us? That's always been an issue, is that recruitment.
Those are all excellent questions and all things that we're trying to think about. Though we know that our desire is to have kids receive exactly the number of services that they need. Some children are going to receive exactly what they're receiving now, and that's all they need. But there are other kids that I think honestly, and I think we know as a system, because I've talked to a lot of you, we know that you would serve them more if you could be reimbursed to serve them more. And so we want to make sure that happens. How will we staff that on the backside? How will we develop new programs? Those are all things that we've got to figure out as a system, but it doesn't mean that we're not moving in the right direction. It means that there's just additional problems we got to figure out, and additional solutions that we have to create. And so the answer is yes. That's another reason we believe that we will need additional programs, because we believe that you as programs, not all kids will receive additional services, but we believe there will be many kids that receive some additional services. And because of that, that will max out your staff time, serving maybe the same number of families, but with more services. And so how do you then backfill and staff on the other end? Those are solutions we've got to work through together.
Okay, thank you.
And I want to say Jessica Edmondson has had her hand raised for a long time. So Jessica, you have a question?
Yes, thank you. I was just about to jump in too. So your timing is great. And so that's what I was going to talk about. Shay, you mentioned this a little bit earlier as far as the plan, if you will. So I was curious how there are several different facets and components to what is being proposed. How is the plan going to be rolled out? I'm assuming in phases, and then two, how are programs going to have input into the plan and the solutions, Commissioner Burdishaw, that are being recommended?
Well, I think that's more of a commissioner question than a Shay. I know what accounting is able to do at this point and prepared to do, and we're working with the programs as far as just certain mechanical things that need to be in place to be able to support any new structure. So I think that that's probably better answered by the commissioner.
I'll jump in. First of all, we're going to meet with you regularly. Second, we're going to listen. So in the first meeting, after our first meeting, our ICC meeting here in person, several of you came to me and to Amy and Shay, and you said, hey, if you do this, when you do this, do this. Because if you don't do it together, and they were talking about specifically about when we shift to the new rate structure, make sure that you also, that you have parts of these solutions move at the same time so that we do as little damage, if you will, or that we move in a positive direction at the same time. I heard you, Amy heard you, Shay heard you. Obviously, we don't know when we will receive approval from the Alabama Medicaid agency. We can't do anything until we have answers there. I can't tell you what's going to happen with Mo until I have further conversations with Commissioner Boswell and determine where we're moving with DMH funds. So those are questions that I don't have answers. You will receive plenty of lead time before any of these decisions go into effect. You also, as we begin to implement these changes, will be part of the policy-making decisions to help us figure out how to, as a system, how to respond in our policy and set up parameters for each of those service provisions. So that was rambling, and I'm sorry. I'm trying to answer the question as best I can.
This is Jessica again. There is a lot of information, and you and the team are doing a stellar job as far as answering. I guess what I'm a little bit confused on is it sounds like this is a given. It sounds like a lot of the verbiage or the use of is when and not if, and so I am curious about that, as if we're moving forward when, not if.
So the when is with the actual rates. The other is solutions that we figure out how to then respond with that rate structure in mind. We know what it costs you to provide a service, and we want to reimburse you for that service provision. That is why we paid funds to have this rate study completed. And 90, let me think of it, 90, what was the total percentage that participated? It was most of you that participated in the time study. So we're very confident in the data. So yeah, it's not and I think Jane, I'm not sure, I think it was Jane Dewar in the ICC meeting, for those of you that weren't there, asked the question and really said, we really don't have an option but to shift because we're going broke as a system. And that's true. You know that I have worked really diligently with the Alabama State House and the legislators there to get as much state funding as possible. But when I continued to add state funding, the questions came of, what are you doing to analyze why you continue to run out of money as a program? That is why we did this rate study, and then we need to respond to the rate study. So I hope that answers the question.